something I'm very. My name is Dr. Akullo. I'm the president of the Uganda Pediatrics Association. And like requested, I am going to give just a brief overview of who the Uganda Pediatrics Association is. Now, the Uganda Pediatrics Association is an association of healthcare professionals, including pediatricians, pediatric nurses, and other health professionals who are passionate and have an interest in pediatrics and child health. We were founded in 1998. It's an old association. And our patron is the Minister of Health, who is also a pediatrician. Our vision is to see all children grow up and reach their full potential. And so we do this in several ways. One of them is this, so through really education and spreading awareness, but we also do it through research, through advocacy, through training, and through a number of other activities. We have our membership, the principal members are the pediatricians, but then we have also honorary members who have really expertise or experience in a specific field. And then we have the associate membership, and that is where we have the postgraduate students who are studying to be pediatricians, and any other healthcare professional who has a passion for pediatrics or who has a bias towards pediatrics. It has a membership of over 300 members, and our members spread all over Uganda and also in the diaspora. We also have regional branches, the Western branch, the Northern branch, Eastern and Central branches, and we do different activities. This is just one of them, but we do, in addition to that, increased advocacy activities. We work closely with the Ministry of Health and try to align our activities as much as possible with that. Now, childhood cancer has been given like this reduced awareness or inadequate awareness about childhood cancer. And I think that's why the Busagwa Health Forum thought it was fit for us to come and just give an overview of childhood cancer. So I'm not going to spend the next 1.5 hours giving us a fellowship in childhood cancer, but I'll just give an overview so that we are familiar with childhood cancer. And the next time we are faced with a child who we are suspicious of, we will know what to do and where to refer the patient. So with those few remarks, I'm going to share my slides and then we can start the discussion for the day. I recognize everyone who is present here in their different capacities. I know people are here from different regions, different areas. So I recognize everyone. I recognize all protocol. Okay, kindly confirm that you're able to see my slide.
Yes, Dr. It's visible.
Okay, and also confirm that's in presentation mode.
Yes.
Okay, so that is our logo, and our slogan is that children are our future. So if we care for the children, we safeguard the future. Now, the objectives for today's session are going to be 5. To understand the burden of childhood cancer, we shall look at it globally, but also locally. But I will dwell a lot on the recognition of the symptoms suggestive of childhood cancer, then just give an overview of the diagnostic procedures and treatment modalities for childhood cancer, talk to some of the cultural and societal perspectives, and then the impact of childhood cancer. And then maybe we'll discuss the next steps of what we can do. I'm hoping that this presentation is going to be a starting point to us spreading awareness about childhood cancer, and that probably after this we can have some discussion on the way forward on how to improve the outcomes for childhood cancer. Now, one of the most common questions I am asked, or we are asked as pediatric hematologists and oncologists, is what causes cancer? So the first thing when You give a diagnostic talk to a parent or a caretaker about their child having cancer. The first question is always, um, what caused it? And then the second question is, does it cure? So I'm going to attempt to answer the two most commonly asked questions. Now, really, this is the pathogenesis about childhood cancer. Just to mention that childhood cancer, most of 95% of the time, we're not sure, there's no cause to the childhood cancer. But regarding the pathogenesis, I'll just describe it simply as a mistake during normal cell division. We all know what happens during normal cell division. There's mitosis and there's migration. There are different things. There's splitting of the DNA, and then there are repair processes that go on. So what happens during cell division, I will call it a mistake or an error happens. And it can happen at any stage of the cell division process. And now this cell where the mistake has happened then gains certain advantages or certain characteristics different from those of the normal dividing cell. Ideally, the normal dividing cell has a lifespan. For example, the red blood cells have a lifespan of 120 days. The platelets have their lifespan. Each of the cells in our body has a lifespan. So the idea is the cell divides, it grows, it undergoes what we call apoptosis or cell death, and the life cycle continues. That's why your ear doesn't grow bigger than it's supposed to be, or your head doesn't grow bigger, because they're regulatory processes. Now, what happens in a cell, in a cancer cell, is that some of these processes are either evaded or they're bypassed. So one of the things that happens is that cancer cells kind of resist cell death. So there's a tendency towards immortality of the cancer cells. That's why you find tumors just grow and grow and grow uncontrolled. They also have a tendency, a characteristic of evading growth suppressors, because again, like there are controls in the body where there's repair and there's growth suppression, but the cancer cells tend to evade this. They have the characteristic to invade where they're not supposed to be. Ideally, a cell from, say, a lymph node is not supposed to invade other tissues, but cancer cells then develop this ability to be able to invade other tissues and even metastasize and go further. They have the characteristic of replicative immortality, inducing angiogenesis and their own blood supply, and sustaining the proliferative signaling. So and this happens because one, there's loss of cell cycle regulation. So the cells just grow and grow and grow. Then there's also failure of DNA repair. So ideally, during the cell division cycle, what happens is if there's any defaults in the DNA, there's a repair mechanism or destruction that happens. But cancer cells uh, they have the characteristic of bypassing this DNA repair. So the cells continue to grow. They are very messy, they are very disorganized, but there's no repair happening. And so these abnormal cells just continue to grow uh, uncontrolled. There's loss of cell death, which is the loss of apoptosis. There's uncontrolled cell division, like I mentioned earlier. Then they have the ability to metastasize, and they have a survival advantage over the normal cells. And these kind of characteristics of the cancer cells are basically what is responsible for the clinical features that cancer presents with. And I will talk about that in the next few slides. So why is it even important to discuss childhood cancer here today? I thought this table would give you kind of like a bird's eye view of what the gap is and what the burden is. Now, worldwide, uh, approximately 400,000 children between 0 and 19 years are diagnosed with cancer. But over 70% of these children are actually in the LMICs and 40% in Africa alone. So that means the majority of childhood cancer is in Africa, in the low and middle income countries. But when we look at the event-free survival, and just taking an example of acute lymphoblastic leukemia, If you look at the survival gap, in the 1955s, we are nearly at the same point, but slowly the high income countries have gone with advances in treatment and they're up to over 80% in survival, while the low income countries have kind of sluggered down and plateaued around 30% in survival. So that shows you the survival gap, and that shows you the reason why we need to discuss childhood cancer, figure out reasons for the low outcomes in low income countries, and think about ways to address this disparity. Now, in Uganda, it's estimated that 3,000 children develop cancer every year, but only about 30% of these children reach the cancer treatment centers. Now, we know that the cancer treatment centers are mostly located in the central, which is in Kampala. There are two childhood cancer treatment centers at the Uganda Cancer Institute and Mulago Specialized Hospital. And then there is a cancer treatment center in Mbarara and one in Gulu. There are 4 cancer treatment centers in the country. So with over 3,000 children developing cancer every year, very few actually get to reach the cancer treatment centers. And the figures that we see, or the children that we are treating, is just about a third of the number of children who develop cancer each year. That means many children are still dying, undiagnosed and unrecognized. And 75% of these children who present to the cancer treatment centers present with advanced disease. And this delay in presentation, certain studies have shown that it's more common among families with low socioeconomic status, low education background, who tend to seek alternative medicines before they approach the cancer treatment centers. The survival is also low, just like the graph I showed earlier, only about 20 to 30% of these children cure. Because by the time they appear late, disease has metastasized and they have several other comorbidities, which makes treatment very difficult. Now, what are the most prevalent childhood cancers? I just made a comparison of what is seen worldwide and what is seen in Africa. And basically, what we see in Africa is very, very much what we see in Uganda in terms of the most prevalent cancer. Worldwide, the most prevalent childhood cancer is leukemia, followed by brain tumors, and then non-Hodgkin's lymphomas and the kidney. Now, these are similar in the high income in Africa, though the lymphomas are the most common, then followed by the leukemias, the kidney tumors, and then the brain tumors, and then the other cancers come down. But if they ask you what are the most common 4 of the top common cancers, it's the leukemias, the lymphomas, the non-Hodgkin's lymphomas, where Burkitt's falls, the kidney tumors, especially the Wilms tumor, and the brain tumors. Now, with a more increased use, so if you read literature of several years ago, you will realize that KS seemed to be the leading cause of the most common, or among the top most common childhood cancers. But with the widespread use of ARVs, KS actually is becoming less and less common among children. The survival in Africa, I mentioned earlier, just giving the example of acute lymphoblastic leukemia, that it was really low, around 30%. Now, there was a systematic review that was done by a team of people that looked at the baseline survival rate of the 6 GICC index cancers in Africa. And the 5-year survival rate was found to be just about 40%. Of course, there is the upper middle income and then the low middle income. And the upper middle income are close to the high income countries of over 80%, while the low middle income countries come down to about 18%. So the average is about 40%, but there is a big variation. But even then, there's a variation in the treatment regimens that are given in the different areas and the different lengths of follow-up. But this is what could be found from that systematic review. And even within the same region, there are disparities in survival. Now, what You may ask some of the determinants of the childhood cancer survival. One is the health infrastructure. I have just mentioned that in a country of over 45 million, we have only four childhood cancer treatment centers. Uh, so there's limited access to diagnostics and treatment. And even when they reach the cancer treatment centers, because of the lack of supportive care, sometimes it's difficult to administer the very high intense curative regimens, and so lower intensity regimens are used. Now, there's also late presentation, and late presentation means they come with more advanced disease. More advanced disease means metastasis and inability to cure these children, or in addition to that, comorbidities like infections and malnutrition. There's also limited supportive care, and supportive care ranges from things like blood products. There are places, for example, where certain blood cancers are not treated because of the lack of platelets and other blood products. So these have to be referred to the central, where the supportive care agents are available, but other supportive care things like nutritional supplementation, the required prophylactic antibiotics and antifungal treatment is limited. So, which makes it hard to give the dose intense regimen that are curative, and hence in most low and middle income countries, lower intensity regimens given so that to balance between really cure and treatment related mortality. And there are also increased rates of treatment abandonment. I think in the UCI they mentioned a treatment abandonment of up to about 50%. Certain places have brought it lower down to 12 to 20%, but the treatment abandonment rates and the missed appointment rates are still high. And with treatment abandonment, it means there are increased rates of relapse, and hence even uh, relapsed tumors are very difficult to treat and cure. The other thing that causes this poor survival in the low-income countries are comorbidities like poor nutrition status and other infections that the children present with, which makes it very hard for them to withstand the chemotherapy regimens, and some of them succumbing to treatment-related mortality or receiving low-dose chemotherapy to avoid treatment-related mortality. Low socioeconomic status is a big issue. One of our colleagues did a study in Bara, and which showed that most of the patients did not return because of lack of money. Cancer treatment is prolonged. Sometimes something like acute lymphoblastic leukemia is treated for up to 3 years. And it requires repeated hospital visits. So most patients who come from low socioeconomic status end up failing to return for their appointments, eventually abandoning treatment and dying from disease progression. And then the big thing that we are trying to address today is the inadequate uh, awareness. Let me not say education, inadequate awareness and research capacity. So we are mostly relying on research studies done in the Western world and protocols for treatment in the Western world because of the inadequate research for childhood cancer in our setting, but also there's inadequate awareness where patients, even if patients present early to the primary health care, the primary care physician, if there's inadequate awareness of childhood cancer, these symptoms are going to be diagnosed as something else, as we shall see later in the presentation, and hence the patients still end up being referred late to the tertiary treatment centers. So before we go on to the presentations, like I said, one of the questions, the most common questions are, what are the causes? Now, we can only talk about risk factors or associated factors, but in 90% of the cases, the cause of childhood cancer is unknown. Now, there are certain studies that have shown certain infections have been clearly related, associated with childhood cancer, like HIV, uncontrolled HIV predisposing or being associated with Kaposi sarcoma, the epidemic Kaposi sarcoma, EBV and malaria being pathogenic in Burkitt's lymphoma. Certain studies in Malawi have shown that the co-pathogenesis of EBV and malaria in in the pathogenesis of Burkitt's lymphoma. Hepatitis B being responsible for hepatocellular carcinoma and HHV8 as being one of the other viruses that predispose to malignancy. There are also certain genetic risk factors like Down syndrome. Children with Down syndrome are more likely to develop leukemia than their non-Down syndrome counterparts. There is neurofibromatosis that has been associated with certain brain tumors. Certain other syndromes like the hemihypertrophy syndromes or Beckwith-Wiedemann associated with hepatoblastoma and Wilms tumor. Again, even in like the so many Wilms tumors you receive or hepatoblastomas, you might find only one associated with this syndrome, and most of them really have no risk factor that can be identified. Chemotherapy is a risk factor for development of secondary malignancies. If you can treat a child, say, for a solid tumor, and then they come back with a leukemia as a result of some of the chemotherapy agents that they have received or radiation therapy. There are also certain cancers that tend to be hereditary. And again, these are very few. Retinoblastoma is one of them, especially retinoblastoma that's developed very early and is bilateral. There are certain familial leukemias and certain skin cancers as well that can be hereditary. Then others like ionizing radiation, especially post-radiation therapy, uh, patients occasionally may develop leukemia and brain tumors. And again, like I say, these are very, very few. This is everything I'm talking about is in the 5%. The 95% is unknown. And then immunodeficiency, both congenital and acquired immunodeficiencies, can predispose to the development of malignancy. And I mentioned HIV as being associated with Kaposi sarcoma. And then, of course, there are others like chemical exposures, parental smoking, alcoholism, birth weight. All these are being found to be associated, but again, in very few patients. Now, what are some of the warning signs? And again, this is now another place that I'm going to spend some time on because recognition is the most important first step. And then after that, appropriate referral. So the warning signs, you can use so many different acronyms for these warning signs. So if we use, say, the child cancer acronym, C for the continued unexplained weight loss, H for headaches, often early morning, that would be suggestive of something like a brain tumor. Increased swelling or persistent pain in the bones, joints, or legs. That could be a leukemia, that could be a bone cancer. Lumps or a mass, especially in the abdomen, neck, pelvis, or armpits. D, development of excessive bruising, bleeding, or rash. Constant, frequent, persistent infections, a whitish color behind the pupil, nausea that persists, vomiting without nausea, constant fatigue, noticeable paleness, visual disturbances, recurring or persistent fevers. Now, if you look at all these warning signs, you realize these are all non-specific signs. Any disease in any childhood disease may present with these symptoms. So it takes a very high index of suspicion, but also very good history taking and clinical evaluation. Now, on the other side, you look at pallor, bruising or bleeding, general bone pain will point you to something. Lumps, again, is repeated there, unexplained weight loss, headaches, abdominal swelling, eye changes, limb pain, fatigue, lethargy, changes in behavior, such as being withdrawn, dizziness, or loss of balance. So occasionally we've diagnosed those some brain tumors late, and it's just that the patients presented early with changes in handwriting, changes in behavior, and they were, labeled as being naughty or stubborn until they develop clear cranial nerve palsy or a localizing symptom. and then the brain tumor is diagnosed. So first of all, increased awareness, high index of suspicion, and then a detailed evaluation of a child is very key. So let's go through each of these symptoms one by one. So we talked about pallor, bruising, general bone pain. Now remember, pallor can be any cause of anemia. It could be iron deficiency, it could be anemia of other causes. Bruising could be due to trauma, it could be to infections, but the hematology oncology diagnosis, the differentials are leukemia. It could be a plastic anemia. It could be a bleeding disorder from hemophilia. There could be platelet problems, or it could be a metastatic uh, malignancy to the bone. Solid tumors can metastasize to the bone and cause myelosuppression, and the patients end up with bruising. So a patient who comes with unexplained anemia, they're having bruising without trauma, no history of, previous bleeding tendency or hemophilia. This patient should be investigated for leukemia or for a malignancy. Let's look at the lumps. So the lumps can appear anywhere. You can see them in the eyes. You see them in the cervical area. You can see them on the scalp. Okay. So when you look at these lumps, I mean, cervical lymphadenopathy could be TB. It could be other causes of lymphadenitis. It could be HIV. It could be an abscess. But key differentials in oncology, lymphomas will present like that. Both Hodgkin's and non-Hodgkin's lymphomas. Leukemia will present with multiple lymphadenopathy. Solid tumors like neuroblastoma, rhabdomyosarcoma, Kaposi sarcoma can all present like this. So again, high index of suspicion. If you see a child matching any of these descriptions, after you take your clear history, of course, you need to exclude the other infectious causes, but let cancer be one of your differentials. Abdominal masses. Okay, these are probably the easiest to identify. But an abdominal mass can be anything else. It could be hepatosplenomegaly, it could be gas, it could be perforation, it could be cysts. Okay, but again, with clear history, you will know that abdominal distension that is related to a malignancy, it's chronic. Most of the time, it's non-tender. It becomes tender later, associated with the other B symptoms. So think about oncological differentials like cancers of the kidney, like Wilms tumor, cancers of the ovary, like the germ cell tumors, cancers of the liver, pancreas, the adrenals, like neuroblastoma. Think of lymphoma, think of other germ cell tumors and any other rhabdomyosarcoma, non-rhabdoid soft tissue sarcomas, anything in the abdomen. Think about the structures in the abdomen. A malignancy of the abdomen can appear like that. There are also eye changes. One of the most common eye changes is what we call the cat eye, that whitish discoloration of the pupil or the loss of the red reflex in retinoblastoma, but this can be confused with cataract. It can be confused with the patient just needing specs when they have some refractory error or some eye muscle weakness. But there are oncological differentials like of retinoblastoma. You can also have a rhabdomyosarcoma in the eye. You can still have a Burkitt's lymphoma affecting the eye as well. Limb swellings, okay? Limb swellings, and sometimes these limb swellings uh, can be triggered by trauma. Patient might get minor trauma and the mother will say, oh, we fell and that's why the limb swell. But if you take a very good history, they may have had pain before that. Or this broken, or the fracture could be just a pathological fracture because of an already weak bone. Now, limb swelling could be due to so many things: osteomyelitis, cellulitis, arthritis. But we need to be aware of the hematology and oncology differentials. And the oncology differentials, leukemia, bone tumor, okay? And depending also on the age of the child, but it could also be other hematological differentials like sickle cell disease and thrombosis. But today, since we're talking about childhood cancer, think leukemia, think bone tumor, think any other soft tissue sarcoma, that like a rhabdomyosarcoma or other sarcomas of the soft tissue. Unexplained weight loss, again, several differentials for unexplained weight loss, non-oncological differentials, but oncological differentials, leukemia, lymphoma, uh, any other childhood cancer, Wilms tumor, neuroblastoma, rhabdomyosarcoma will present with chronic unexplained weight loss. Again, take a good history, take a good physical examination. Fatigue, lethargy, changes in behavior. This can have so many things. The fatigue could be because of anemia, which could be nutritional or could be due to bone marrow infiltration. It could be infection, but also oncology. It could be a leukemia causing the anemia, and these changes in behavior, unusual behavior, poor school performance, being withdrawn could actually be one of the early signs of a brain tumor. Okay, and then dizziness, loss of coordination again could be a brain tumor, but also the non-oncology core differential could be an ear problem. So I just wanted to flash these slides to show you that childhood cancer will present with symptoms of any other childhood illness, but it takes being keen, being aware, and being intentional about really probing the history of childhood cancer to be able to identify it early. Okay, and how would you approach childhood cancer? Now, approaching the diagnosis, now you've seen the differentials. Approaching the diagnosis also will need you to be aware of one, how does it present, but also two, uh, what are the more likely cancers at a certain age? I mean, to develop your list of differentials. So in the younger age group is where you will expect cancers like the neuroblastoma. Those are in the infants and the young children, 2 years and below. Retinoblastoma, also in the younger children, the Wilms tumors, 5 years and below. But it doesn't mean you can't get them in older children. The sacrococcygeal teratomas, the germ cell tumors, hepatoblastomas in the infants, lymphoblastic leukemia. But as they get older, if you go to the older age group, then you begin to get bone tumors, the Hodgkin's lymphoma, the gonadal germ cell tumors, the AMLs, the non-lymphoblastic leukemia. Having said that, these tumors can occur in any age group, but there are certain age groups where they're more likely to occur than others. And also the presentations of childhood cancer will present one because of the cancer itself, but also it can present because of the metastasis. Remember, we said if somebody has, for example, anemia or myelosuppression, it could actually be a solid tumor that is suppressing the bone marrow and not necessarily the leukemia. Okay, it can also present with the paraneoplastic syndromes, like some kids come with electrolyte abnormalities due to certain tumors, but it can also because of the tumor invasion or compression of certain sites. The children who will come in with large mediastinal masses. So some of these children come in respiratory distress. They either have a pleural effusion or a mediastinal mass, and occasionally these children are treated as pneumonia, and if they're unlucky, they die on the ward being treated for pneumonia. And yet, if further interrogation was done, this child would have been diagnosed with, say, a mediastinal mass or a pleural effusion secondary to a malignancy. So these are some of the presentations, and it takes being keen and having a high index of suspicion to be able to diagnose or at least have a differential of childhood cancer. So now the question is, when you suspect cancer, so given the symptoms that I have described earlier, and also the brief idea of what cancers tend to appear at a certain age, what do you do when you suspect childhood cancer? Key is take a comprehensive history, okay? Clear history, bone pains, no trauma, someone is anemic, they haven't been bleeding, it's persistent over a period of time, constant weight loss. Take a very comprehensive history, find the different associated factors. Then after you take a comprehensive history, perform a thorough clinical exam. And that takes examining head to toe. Okay, because one, you want to find maybe the site of the tumor, but also you want to check for the metastatic sites and any other complications. So a thorough clinical exam. Then, depending on how the child presents to you, at the level, I have been told that my audience is mostly primary care physicians. So at the level of the primary care physician, one of the things you can do is a supportive care. If the child is anemic, transfuse. If they're dehydrated, some blood. If they need respiratory support, provide that supportive care. If they're thrombocytopenic, provide that treatment. And then start the initial diagnostic testing. Diagnostic testing can be started at the primary care level. A simple complete blood count can show you a CBC that is suspicious of a leukemia or a hematological disorder. A peripheral blood smear will be able to show you the cell morphology, and you might be able to see blasts on the peripheral blood smear. And then consultations and referral are very key. At the primary care level, you don't need to start any form of treatment, but really um, early appropriate consultations and early referral for these children to the treatment centers is very key. And then offering psychosocial support to the families. Now, how do we diagnose childhood cancer? I'm trying to rush through so that I make good on the time and we have some time to discuss. So the diagnosis of childhood cancer will depend on the cancer type. It will depend on the signs and symptoms of the child's presentation, the age at which they present. I gave you an overview of what is more likely at in a certain age group, the general health and the results of any prior tests. So we can do baseline tests like a CBC, for example. We'll be able to show you if you see abnormalities, for example, in the cell count, a very high white count, low HB, low platelet count. So we may call it either bicytopenia or a pancytopenia. That should already make you start thinking. If occasionally I have had patients who had a very high white count, low HB, low platelet count, and they're pumped with antibiotics that they have infection. So it really takes somebody to look keenly to be able um, to notice that the CBC is abnormal, and hence it might be more than just a reactive inflammatory process and something more than that. The other thing that is very helpful is a peripheral blood smear. And if you can do a blood smear for malaria, a thin smear for malaria, you can actually do a peripheral blood smear to diagnose a red blood cell or a leukemia, a blood abnormality. It just takes doing what a reverse field stain or a GEMSA stain, and you'll be able to see if you see on the lower right slide, you see the cells that are much larger than the red blood cells in the neighborhood. They have some bit of cytoplasm. There are certain, this is basically a cell of a patient, a peripheral blood smear of a patient who has acute lymphoblastic leukemia. Now, the other thing is, of course, the other fancier tests like what we call a flow cytometry that now helps you nail down completely what type of leukemia it is, whether it is a B cell, T cell, or a myeloid. But this is enough at the primary care level. This is enough for you to refer a patient. Tissue biopsy is very key. We have a saying in childhood cancer that where tumor is a rumor, tissue is the issue. So tissue biopsy includes taking tissue from any of the swellings. Okay, the tissue can include a bone marrow aspirate and biopsy, but it can include tissue biopsy from any of the sites, any of the swollen sites. We can also analyze body fluids, including CSF, including ascitic fluid, including pleural fluid. All that those can be analyzed for malignancy. Imaging studies, if a patient comes with a swollen abdomen, a swelling, a lump somewhere, an ultrasound scan is very handy, and this is available in most of the primary care settings. A chest X-ray available. You can easily diagnose a chest mass based on a chest X-ray, a widened mediastinum. I mean, it can be a number of differentials, but cancer can be one of your differentials. A CT scan, if you see on the upper right, that's a CT scan of a patient who has a kidney tumor. So you see the right kidney looks fine, but the left kidney is obviously consumed by the tumor. That's what it looks like. MRIs are good, especially for the brain and spine, and then the PET scans are also used where they're available for making diagnosis and also for follow-up of treatment of patients with Hodgkin's lymphomas and certain bone tumors. Then, of course, there are other emerging tests. There's genetic tests that are done to really identify specific genetic abnormalities, because now we are getting into targeted treatments and immunotherapies that target certain genetic abnormalities. And then there are also other emerging tests like liquid biopsies that are being performed in the high income settings. Now, talking about the treatment of childhood cancer, what are some of the principles of management? One, it's multidisciplinary, multimodality, and then throughout the treatment, there has to be lots and lots and lots of supportive care. Cancer treatment cannot be given without supportive care. Now, let's talk about the treatment modalities. Like we said, it's multidisciplinary. So we always have a joke in the cancer treatment unit that you give a child chemotherapy and then suddenly the ward turns into a renal ward, because then now you have AKI and you have electrolyte abnormalities and you have to manage all this. So a childhood cancer patient has to be managed with a multidisciplinary team, because at any one point in time, either because of the cancer itself or because of its treatment, you're going to get complications that require other disciplines. Now, there are standard therapies, which can be local or systemic. There are basically three main pillars for the treatment of cancer. There is surgery, which is a local therapy, there is radiation therapy, and chemotherapy. Some cancers can be treated with chemotherapy alone. And the role of chemotherapy can be to get rid of the cancer. So cancers like leukemia can be treated with chemotherapy alone. Lymphomas can be treated with chemotherapy alone. They may not need any local control. And chemotherapy can be used either as the only treatment or as what we call the neoadjuvant to first reduce the tumor, to make it either operable or responsive to chemotherapy, or it can be used as adjuvant, that is after surgery or after radiation therapy. So the other key treatment is surgery. All tumors in solid organs need surgery for local control, apart from those that cannot be controlled by surgery, that then get radiation therapy. Some of the tumors need all three treatment modalities. Some require two treatment modalities, some require just one treatment modality. The chemotherapy can be given either IV or orally. And then there's hematopoietic stem cell transplant that is relevant in certain conditions, like in relapsed leukemias, for example, that might be relevant. And then, of course, the emerging treatments, some of them are not yet available here, some are. So targeted therapies, I mentioned certain cytogenetics. There are certain cancers, for example, I think we're all familiar with the Philadelphia chromosome. There are certain cancers like CML or even ALL, which has the Philadelphia chromosome that actually responds to tyrosine kinase inhibitors. So once that is identified, targeted therapy is given to these patients. The non-Hodgkin's lymphomas, Burkitt's lymphoma, can now be treated with an anti-CD20, that is an antibody, rituximab. So those are what we call the targeted therapies. Then the immunotherapies that are used in more advanced places that target also certain specific points in the cancer pathogenesis, like the immune checkpoint inhibitors or the chimeric antigen T cells, the CAR T cells. So, what is the status? Having said all that, what is the status of the pediatric oncology services in Africa? Then we shall go to Uganda. Now, I spoke about the three standard therapies: surgery, radiation therapy, and chemotherapy. Now, in a survey that was done, only 9 out of 48 countries that were surveyed had all the three treatment modalities. So that means there are areas that have chemotherapy and maybe surgery without the radiation therapy, and vice versa. So you begin to understand why the treatment outcomes are not as good. And then 2.5% of the African population had no pediatric oncology services altogether. So either these children are being referred or they're dying without diagnosis. And there are 25 countries that had no radiotherapy completely, and yet radiotherapy is an integral part of some of the childhood cancer treatment, some in the treatment of some of the childhood cancers, like the brain tumors, for example, and the rhabdomyosarcomas and the Wilms tumors. Some of them must be treated with radiation therapy. In Uganda, we have 4 treatment centers in Gulu, and you can see how they are spread: Gulu, Mbarara, and Kampala. 2 in Kampala at the Uganda Cancer Institute and at the Mulago National Referral Hospital, and then in Gulu and Mbarara. Those are the 4 treatment centers that we have for childhood cancer. We are lucky that now we have 2 ongoing pediatric fellowship programs, one at the Uganda Cancer Institute, and then that I think takes 2 fellows a year, and then one at the Mulago National Referral Hospital that takes 4 fellows a year. So with this, the number of pediatric oncologists has increased from none in in the 2000s to at least 12 as we speak. So that is a good progress. But you realize that 12 pediatric oncologists is still not enough to treat a 3,000 new diagnoses of childhood cancer. That we see that is estimated in Uganda every year. And that's why we need all hands in, and we need the awareness of the primary care physicians to help in this fight. There are other things that hinder childhood cancer care, including the cultural and the societal beliefs. The stigma and misconception. We have visited some homes of our childhood cancer survivors where they have thought to be practicing witchcraft and been alienated from the village. So some of them don't even like the doctors to visit them. Their beliefs that the causes are supernatural. This is not new to the team that I'm talking to. There are also traditional healing practices where patients have left treatment in the hospital and gone to seek care among herbalists. But there are also financial and socioeconomic challenges, like the decision-making dynamics, where certain, say, the mothers cannot bring the children to the hospital because the fathers, who are the breadwinners, do not believe in the cancer diagnosis and are not going to give them money. And they've been given ultimatums to either leave the home or stay home with the child. There are religious and spiritual coping mechanisms where we've had parents and taking children out to go pray and default treatment. Then, of course, there's impact on family dynamics. Families have blamed each other for being the source of the cancer, and hence we've had families breaking after a cancer diagnosis. And they also need a lot of community support and advocacy, and that's why we are having this talk. Minus this, we cannot address the issue of childhood cancer. There are also myths about childhood cancer. Even among the land, people think that childhood cancer does not exist. And if a child is diagnosed with cancer, there's a belief that cancer treatments don't work. There's also a belief that it's expensive to treat because of the several. So I think for all these myths, we have clearly seen that cancer exists in children. Now, regarding whether cancer treatments work or don't work, you've seen the survival in the high income settings have gone up to above 80. And this is because of years of research and work in childhood cancer, and the childhood cancers that are actually very highly curable, and they're curable if diagnosed early and if we use the right treatment approaches. Being expensive to treat, cancer treatment now, at least on the Hill and in the public settings, is free. A few tests may not be readily available, but there are collaboratives and supportive networks that are making cancer treatment easier to access, and the investigations and treatment is free. So it is not that expensive. Of course, it's expensive if the patients have to travel and then have to lose their sources of income. Those are where some of the expenses come from, but the cancer treatment itself per se is free. Of course, there's a belief that it's contagious. Cancer is not contagious. about it being genetic. We've seen that 95% of the cancers actually, as I'll use the word sporadic here. The cause is unknown. There are very few that are hereditary and very few that are associated with chromosomal abnormalities. Childhood cancer is preventable and easily screened. That is false. Because we say there is no known cause of childhood cancer in 95% of the cases. This makes prevention impossible, and it makes screening for childhood cancer also is it's not something that can easily be done. Apart from, say, if you have a familial thing like retinoblastoma, and again, that is in very, very few cases. So the most important thing about childhood cancer is early recognition, early diagnosis, and prompt treatment. That's where we go with childhood cancer. It's not the same as adult cancer where they say screen and prevent. For childhood cancer, it's early recognition, early diagnosis, and treatment. And then that cancer surgery causes spread. If cancer surgery is done right, using the right protocols, surgery is actually curative for most of the solid tumors. Okay, what is the impact of childhood cancer? I will summarize it in the four toxicities of childhood cancer. I want us to have at least 30 minutes for discussion, so I'm going to rush through this. Childhood cancer has an impact not just on the patient, but on the family, on the community, and on the country. So I decided to divide it into four toxicities. The disease toxicity itself. So depending on where the cancer is, you've seen how the children present: fatigued, tired, deformed, in pain. So that is all from the disease, okay? And sometimes they may die from the cancer itself. It causes some of them, then there's treatment toxicity. Okay, so treatment toxicity will start with both acute and chronic toxicity. The acute toxicities will be things like poor appetite, hair loss, skin changes, weight loss, nausea, vomiting. But there are chronic toxicities where we have certain drugs that may cause cardiac dysfunction. Certain drugs may predispose to secondary cancers. Certain treatments like surgery, say for a bone tumor, might involve an amputation. So there are different, so treatment toxicity can be also a big thing, both short-term and long-term toxicities. Then, of course, there's a financial toxicity. Even if the treatment is free, but there is the fact that the family has to leave their home, spend most of the time in the hospital. Most of the families lose their source of income and livelihood because of these repeated hospital visits and repeated hospital stays. And whatever financial resource they have is spent in the back and forth, traveling between the hospital and home, and the other competing needs. Then there's, of course, the psychosocial toxicity. The disease itself causes distress. The older children are usually angry, and there's a disruption in their school life and their social life. But back at home, there's also the issue of stigma and social isolation. And even when the patients survive, reintegration into the community becomes difficult because of the myths that either cancer is incurable or it's contagious, or they'll pass it on to other people. So it makes their integration, or because it's a curse, so it makes the reintegration of both the children and the families into the society very difficult. So, having said that and shown you the burden of childhood cancer, what are the next steps? I think we need to continue creating awareness, including meetings like this, doing workforce training. We need to do collaboration to generate data, to improve infrastructure, to improve resources, to improve our outcomes, maybe to do joint researches. We need to do appropriate adaptation of the treatment guidelines so that we give our children the appropriate treatment without them succumbing to treatment-related mortality, but also while giving them optimal treatment to result in a cure. There's need for investment in cancer diagnostics and treatment, and I hope there are policymakers and some advocates in this room, but more importantly, we need to do advocacy and awareness about childhood cancer. So I have a few references here, and for all our children who complete cancer treatment and go into remission, we usually give them a certificate of bravery or a certificate of treatment completion in a red carpet event. So with that, I would like to thank you for spending the last hour listening to me. Thank you very much. Back to you, Desmond.
Thank you so much, Dr. This timely presentation. I know everyone who is here was eager to get to understand the overview of childhood cancers in the country, and the best presenter has made it today. So I believe that session must have intrigued you to ask more questions, but also maybe seek clarity. So this is the time where you can ask the question, but also you can ask for an clarity, or you can make a comment or an addition to the presentation. I can start with those that are in the chat, then I'll open. I know right now you're all unmuted, but I'll open with the hands up, then you can ask your question. The first one came from Namuri Jane. Namuri asks, where can one get bone marrow aspiration or a biopsy done? Then Resti Nanyonjo, she's happy with the presentation by her comment, wow, but she seeks clarity on the age differences we see with respective cancers. She's wondering why the age predisposition to particular cancers, why the age is a predisposing factor to particular cancers. Okay, then Ivan Funa, are there any malignancies that are attributed to malaria? Most of them are thank you, Dr. And then Precious asks, what is the mechanism of electrolyte imbalance and acute kidney injury in cancers before treatment is initiated? Dr. And do you want to take over those ones before I give you other bunch? Doctor, do you hear me?
Sorry, I was speaking to a muted microphone. I am sorry. So I will start with the last comment on why would some children get AKI or electrolyte imbalances before even initiation of treatment. Now, there are two explanations for that. One, like we said, our most common cancers are leukemias and lymphomas, and these are cancers with a high cell turnover. And there is a concept in cancer called hemolysis syndrome. So these very fast growing cells also die fast. Okay, there's a high cell turnover. So with massive cell death, there is release of intracellular components. So this will include things like uric acid, potassium into the blood, and this can overwhelm the kidney. So the uric acid can cause AKI by causing crystals in there, but also these excess cellular components will cause things like the hyperkalemia, okay, renal damage leading to AKI. So that is one of them, and that's one of the most common causes actually of patients showing up with, say, AKI or electrolyte imbalance as even before they start treatment. Okay, that is the tumor lysis syndrome. The other thing could be the paraneoplastic syndrome. So there are certain tumors that are secretory. So they may secrete things like calcium. So there are certain tumors that will come with a hypercalcemia and different electrolyte imbalances because of what we call the paraneoplastic syndrome, even before they start treatment. Of course, electrolyte imbalances and the AKI is now worse once you start treatment, because once you start treatment for these tumors with high cell turnover, then you're lysing so many cells and releasing a lot of intracellular components into the bloodstream, which overwhelms the kidney's ability to get rid of this. Of course, there are prophylactic things that we do at the cancer treatment units to prevent this from happening. And for those that get into AKI and require dialysis, we can go as far as doing dialysis. That's why when I mentioned childhood cancer treatment, on top of everything we do, supportive care is very key. Now, malignancies associated with malaria, yes, certain studies have shown the dual pathogenesis of EBV and malaria in Burkitt's lymphoma. And that's why sometimes when you follow the belts, some of the malaria belt and the Burkitt's lymphoma belt, they kind of lie around the same belt. So there is that double pathogenesis. But again, like we said, not every person who has malaria will get BL. But in the cells, studies have that the cells that have been studied, EBV, for example, has been found in some of the cancer cells, the bucket cells, and malaria has been also studied as part of the pathogenesis. So yes, there's a relationship between malaria and Burkitt's lymphoma. Now the age and cancer. Now the age doesn't predispose you. So this is what I showed was in studies, what we have seen, what cancers are common in certain age groups. Okay. And that is really, that is epidemiological data showing you what cancers are more common in certain age groups. It's not like the age is predisposing you to a certain cancer. That happens more in adulthood. Now, when we are talking with older age, you get, I don't know, CS cervix and whatever. But in kids, that was just the epidemiological pattern that I was showing. And then the question of where you can get a bone marrow aspirate, you can actually have a bone marrow done even at your facility. If you are trained, we have medical officers doing our bone marrow aspirates. Where we are with proper training, you just need the bone marrow needle. But to answer you, bone marrow aspirates are done anywhere within Mulago Hospital, at the UCI, at the different cancer treatment centers. But every hospital, every general hospital and regional referral hospital should be able to do a bone marrow aspirate. It just takes a little bit of training and the bone marrow aspirate needle. It's a very simple thing. Like if you can do an intraosseous while resuscitating a child, then you can do a bone marrow aspirate. You just have to go to the right site where you're more likely to get bone marrow, and those are the flat bones. We usually use the pelvic bones for the bone marrow aspirate. Okay, back to you.
Thank you. I want to ask if you want to raise, you can raise your hand. I'll take up your question. If you want to do that, I want to see some hands, but as you wait for the hands, Andrew asks, how can rural facilities, or how can rural facility health workers catch hematological malignancies early, given that they can't do CBC or PBF?
Okay, so I don't know how the rural facility is, but I imagine any facility should at least be able to do a field stain for malaria, right? But even before we go to the investigation, remember I said if you suspect cancer, taking a good history. So let's give an example. A child comes and says, I have had history of fevers for 3 months. My bones hurt, constantly anemic. On examination, you see the child is severely pale. The child is bleeding. When you go through your list, malaria does not make you sick for 3 months and make you bleed and make you have joint pains. Like when you go through your list of differentials, if you think leukemia, for example, is a differential, from the history that I've given, someone has been sick for 4 weeks, 8 weeks, persistent fever, persistent bone pain. They are now bleeding. They are anemic. They have some bruising when you examine them, lymphadenopathy. Already from the history and physical exam, you have your suspicion. Now, if you're unable to do any further testing there, refer to your next level. I know health center 4s have CBCs. You refer to your next level. If the health center doesn't have or cannot do the investigation, then refer to the general hospital. Now, like I had mentioned earlier, any place that can do a field stain for malaria parasites, if the physician or the lab person knows how to make a thin film, you can actually just do, so when you do a field stain, you do field A and field B, and then you whatever. Now with the reverse field stain, the same field stain, you start with field B and then field A. You fix the thing in formalin, do field B and then field A. That's what we call the reverse field stain. You can actually go under microscope and make a diagnosis of a hematological disorder. Whether it's sickle cell, you will see sickled cells. If it's a leukemia, you will see abnormal cells. At least it will give you an index of suspicion. You may not be able to nail it and say, this is ALL, this is this, but you will see some abnormalities and that should prompt you to refer the patient. So I think at whatever level you are at, you can be able to do the tests that you can do. Of course, history, physical exam are very important. And if you can do any simple test like a basic blood smear, that's a starting point. And then refer the patient if you're unable to do a CBC or any other further tests. Supportive care, if you can do a simple HB, I know there are certain places that have those small HB things. You can estimate an HB and refer the patient to the next level. I hope that is helpful.
Okay, thank you. There are some more questions coming in, but I hope we shall be in time. Peterson, thanks you for the wonderful presentation, and he wants to know if there will be other studies of the same kind. Then Immaculate Mirembe says, how can we empower regional referrals do good informative peripheral films? They are often not of hope, and is it the gold standard for leukemia? Meaning, if it's negative, relax. Then Geoffrey Zima says, thanks you. Then, are there organizations that support these vulnerable children who come from humble family or backgrounds with diagnosis and any childhood cancer in Uganda? Okay, let me pick more two. Kindly educate on the minimum thing you would like us to do before referral to the treatment centers. Then, and Mukoni Simon, is there a program by Ministry of Health train healthcare workers in health facilities across the country about the awareness of childhood cancers? Because I think we health workers at lower facilities are facing knowledge gap on that. Then lastly, before I get others, what would be the first aid stroke emergency care in far to reach areas to patients who present with TLS? I think, Doctor, you can take over those ones first.
Okay. So, what was the first question about the rural facilities? I wrote rural facilities and I stopped there.
How can rural health workers catch hematological malignancies early, given they can't do CBCs and PBF?
I think that one I explained about taking a good history and being able to do a peripheral blood smear. Now, and then going now to Dr. Immaculate's question about a peripheral blood smear. Now, the peripheral blood smear is not your gold standard. Like I said, it's one of the screening tests, the initial things that can be done simply and most of the time you will actually get an answer. But there are times, like you said, when a peripheral blood smear is done poorly, when the staining is poor, or if the cancer cells are very few in the peripheral blood, you actually may not, you may have a negative, like what looks like a normal smear, but still, the bone marrow aspirate is the gold standard for diagnosis of leukemia because that's where the blood is made. Okay. but we have made some diagnosis of leukemia. You can actually make a diagnosis of leukemia on a peripheral blood smear. But if it's negative, do not stop there. If the patient has symptoms that are suggestive of a hematological disorder and you cannot do anything else after peripheral blood smear, please refer to the next level health facility. Now, while looking at a peripheral blood smear, we are not only looking at the abnormal, so we are not just looking for blasts. You can actually see sickled cells on a peripheral blood smear. You can see the absence of platelets, a thrombocytopenia, or abnormal morphology of the cells. So you might think it's one thing, and then you go and you actually see maybe signs of hemolysis on a peripheral blood smear. So there's so much that a peripheral blood smear can teach you. And this brings me to the question, but it's not your gold standard for the diagnosis of leukemia. You still have to go ahead, refer the patient, have where the patient can have a bone marrow aspirate done and further tests on the bone marrow aspirate done. And now we don't diagnose leukemia only by looking at morphology. I told you one of the tests I told you was a flow cytometry. We go further to characterize the leukemia. We say, okay, now it's a leukemia. Is it lymphoblastic? Is it myeloid? And even if it's lymphoblastic, is it B cell? Is it T cell? Because they all have treatment implications. Some are treated more aggressively than others. So that is the detail in which we go to make the diagnosis. Now, in terms of empowering the regional referral hospital, I think this is something that we need to take back as the Uganda Pediatrics Association and also collaborating with the Ministry of Health, because it's a very, very simple, I mean, there are certain very simple tests that can be done at any level if I think capacity is built. So this is an action point about really building the capacity of regional referral hospitals to be able to do good peripheral blood smears. I will take that back as a suggestion for improvement. Now, what is the minimum expectation to be done before referral? One of the things I mentioned was supportive care. Okay. So if the patient comes to you, any patient, whether they have cancer or diarrhea or a fracture, look at the ABCs and stabilize the patient at the minimum. Okay. Make sure our airway is patent, we are breathing, and our circulation is good. Sometimes the patient comes to you and they're in shock because either they've been bleeding. So evaluate the patient, transfuse if you need to, rehydrate if you need to, control the pain, and then refer. So the most important thing is stabilize the patient before referral. Don't make a diagnosis of cancer, then you refer a patient, say, with an HB of 2 who is gasping and dies in an ambulance on their way. Because even when they reach the cancer center, they're going to be stabilized first before any treatment is started. So if there's an ongoing infection, whatever is happening, stabilize, manage the ABCs, and then refer the patient. But as you're doing the stabilization, of course, have a contact close by. And I think at the end of this, I will share contacts of the different treatment centers and refer to the center that's closest to you. The knowledge gap and what is MOH doing? Again, I will take this back as an action point for us to go and really discuss. We are working, UPA is working closely with the Ministry of Health to handle the issues of newborn health, child health, and this is something that I will take back. I think this is similar to the previous comment to see how we can do capacity building and spread awareness to the primary healthcare workers, especially in the rural areas. TLS, first aid for TLS. Now, like we said, tumor lysis syndrome is basically overwhelming intracellular component in the blood, which is overwhelming the kidney. Okay, so one of the things, hydration. Okay, even if you just give fluids. Okay, so we do things. I mean, we give fluids, we give something that binds the uric acid or breaks down the uric acid called allopurinol. We give different things, but fluids are key. Okay, and if wherever you are, if you're in a regional referral hospital and you're able to manage the potassium say if you've done a renal function test and you have a hyperkalemia. So one of the things with tumor lysis syndrome, the thing that is going to kill them is the hyperkalemia. Okay, you can begin the management for hyperkalemia. If you can manage your glucose insulin, potassium binders, nebulization, that you can do. But otherwise, if you can't do anything else for TLS, at the minimum, hydrate the patient. We usually hyperhydrate. We give 1.5 times maintenance fluid. Okay, next
Okay,
question.
thank you. I want to ask Dr. Paul Waverly to ask his question. Doctor, you can unmute and ask that question. Dr. Paul Waverly.
Thank you. Sorry, I was looking for the unmute button. Thank you very, very much, Dr. Akullo. I'm a board member of SOGA Health Forum, and this is a very important session that I'm attending. Thank you for your time. It's really necessary that we at the peripheral level are able to use the blood slide to be able to predict some of these abnormalities. And I know many of us at that level don't even do a blood slide at all. But when you even talk about reverse staining, none of us even understands that. But also reading a slide correctly to be able to detect hematological abnormalities is another challenge. Is it possible for you to come back on this forum one day and just take us through how do you do the staining? How do you detect different abnormalities? I mean, that could be a starting point as we look for other ways of strengthening capacity at that level. Thank you. Over.
Yeah, I think that is a very good suggestion because I see this forum has a very big audience. So I can actually arrange that with one of our hematopathologists, and we just go through how to interpret the different blood slides. We can stain the slides, go through the process, but the reverse field stain is very easy that we can go through very well on this forum. But the most important thing is once you've got your stain, then interpreting of the slides, and that we can I wait for the invitation to come back with some of our hematopathologists to get to train the team.
Okay,
Thank you.
thank you.
Much appreciated.
Thank you. I want to just take only the last two questions. This has been the longest session that we've had. I want to, is there any, I'm just paraphrasing it. Somebody wants to know if there is a relationship between childhood cancers and food. I'll paraphrase that, but that was the question. I think that's the last question I can have to you, Doctor.
No, and the simple answer is no. There is no relationship between childhood cancer and food. I think we went through a list of the risk factors, and that did not come up in any of them, and there is no relationship. And someone asked about parental refusal of chemotherapy. Yes, when we make a diagnosis of childhood cancer, we have to go through what we call a diagnostic talk, where we sit down and have a whole family conference and explain, because you've seen all the myths about childhood cancer. Sometimes the refusal is based on the lack of awareness and the unfounded fear. And once we go through the diagnostic talk, then most of the parents understand and change their minds. So that's the last I will give. So back to you.
Okay, thank you. I want to invite Professor Peter Waiswa to give closing remarks to this session. I know members have very many questions that may come up, but we shall engage the Uganda Pediatric session that we have more series of such sessions. Thank you so much. Over to Professor Peter.
Can you hear me, Benjamin?
Yes, Prof, we can hear you.
Dr. Ann, thank you so much for this. I actually have a question and a suggestion. The question is, there is talk that at Uganda Cancer Institute, you get specific cancers from Busoga. And that's why you try to do a cancer register and research center in Mayuge. Could you elaborate on that? Then the comment that I want to say is I actually have something I've been struggling with. We try to do it at Resources Forum, but we don't have the resources. So I'm a believer in that there's something I call democratizing medicine. And the democracy of medicine for me is there are so many things that don't require a doctor and it could be done by everybody. For instance, these simple signs you said about cancer, that you cannot suffer from malaria for a month, those are things everybody needs to know, whether a family, whether a church member, whether somebody who has never gone to school. And for the other NCDs, I know that cancer is also an NCD. People just think that NCDs are hypertension and diabetes, but anything that is not communicable is non-communicable. So one of the things that I wanted to do, but I've not been able to do, is how can we democratize some of this information? In other words, is there a way we can package information for households and community members? And maybe we can, and then information that we can also democratize for healthcare workers at the lowest level, VXTs, health center to etc. For instance, if you look at, let's say, diabetes and hypertension, there are many things that we could do by just making information accessible. And then let's say a preacher could have a guide, a reference they use on simple things that people need to know. A politician can actually stand at a funeral and teach people about, let's say, cancers. If there was a simple guide made for either community level and then a guide for different one for health worker, that is what I call democratizing, because we shall never have Dr. Anne reach everybody. Like you said, you are 12 people. But how can we multiply that number in a simple way? So if you could make comment that, then I can close the meeting. And as a public health specialist, I really want to work with you people on this, because this is public health at its best. But sometimes it is very difficult for the clinician to think that people in public health can make a contribution, yet we're into it together. Okay, please.
Yeah, thank you, Dr. Peter Weissler. I mean, those are all very good comments. I will start with the question on the cancers that are more prevalent in Busoga. We were also actually reviewing our statistics very recently, and there's one of the cancers I'm actually looking at, that's Burkitt's lymphoma. And most of our patients with Burkitt's lymphoma come from Busoga, and I think that's the same thing that is being seen at the UCI as well. And so I think the risk factors need to be studied further. So that is the region. So that is if you ask me to answer your question very straightforward, the cancer they're talking about is the Burkitt's lymphoma, which is actually the most common non-Hodgkin's lymphoma in children in Uganda. And we've seen a lot of it coming from the Busoga region. And then, so hopefully when we get that register and are able to study the risk factors further, maybe in another session, we can have a further discussion and clarify what's happening there and what we think is the reason for this high prevalence of Burkitt's lymphoma among the Busoga. Then regarding democratization of medicine and all the suggestions you've given, I think this is good. There is something that's already happening. We were doing this for sickle cell together with diabetes and the Pen Plus team. There is the self-care guide that basically gives simple messages that a VHT can give, a member of parliament can give, like a local community leader can give regarding diabetes, regarding sickle cell. So it's a document that's integrated. What I noticed was there was no childhood cancer in that document. So that could be one of the fora that we could use. But like you said, this is work in progress. We need to work together to develop some of these small leaflets or flyers, education materials that are in very simple language and in future translated to the local language as well, such that people can be able to easily read and have some kind of reference information. So this is something that we need to work, but already with this self-care approach that is being done, I need to follow up with the Pen Plus team because they asked us to give some input into sickle cell disease. Like I said, I didn't see childhood cancer, but now that you bring it up, I think it's one of the things that really needs to be integrated in this piece of this information piece that is going nationwide. But I'm very open to us working together and figuring out better ways to reach a wider audience. Back to you, Peter.
Yeah, thank you so much, Anne. So thank you so much, Dr. Anne, for this. And this is something I'm very interested in. And we are very grateful to you and Uganda Pediatric Association because it is not every day that you get 1.5 hours plus, of course, all your hours of preparation to come and give credibility to this platform. Our platform may sound Usoga, but now we serve a global audience. So thank you so much. And as you will find out, this presentation will be available on YouTube. So you can even send it to groups and even refer people, students, etc., to access it for life. I would like to thank you for making the time, but also making the presentation. And you've shown that just talking about cancer, pediatric cancer, you can take the next 5 years, speak about them. So as you promised, we shall invite you back and also refer to us, other colleagues. We shall provide the platform. This platform has even non-medics that attend to it. Thank you so much. And as a sign of appreciation, we are giving you this certificate of appreciation from the Soga Forum. Please accept it. And now Benjamin is the coordinator of RCMA, and I've also given him a certificate of appreciation. And you might be glad to learn that actually Benjamin is a nurse, a certificate nurse, although now he's doing his diploma, but coordinating all these important things. So showing that we can actually democratize a lot of these things. Thank you so much, and have a lovely evening. You can say your last remarks and say bye to the team here.
No, really, thank you for staying this long and thank you for paying attention. I think it was a very lively and a very participatory audience. So I just want to appreciate everyone for staying this late. It shows your that you prioritize childhood cancer. So I look forward to coming back and working
Thank you,
together.
thank you, and have a lovely weekend. God bless. Regards to the UPA members. Bye-bye.
Okay.